14 mistakes doctors make when treating MS. I've been doing this a long time and I see the same things over and over again, and sometimes I don't agree with other doctors. Now I want to give a few caveats. One is, this is just my personal opinion. Others may disagree, so please talk to your own provider for personal advice. Also, I'm not really trying to disparage anyone here. I'm a neurologist and MS specialist. It's not reasonable to expect an ER doctor to know everything about every disease, but I hope you find this to be informative. Number 1, treating based on current level of disability. This is with respect to making recommendations for disease-modifying therapists. I think for maybe a general neurologist who doesn't have that much experience with MS, they may see a patient who's young, has relapsing MS, and has very low disability. They can walk unlimited distance, they're not complaining about major symptoms, maybe they had optic neuritis and an MRI led to a diagnosis of MS, but their symptoms improve and they feel well. They may think intuitively, I should not give this person a high-risk medication, an immunosuppressant that could cause infections because they look so good. Whereas maybe with someone who has more advanced MS, significant symptoms, significant mobility, and cognitive problems, they would opt for a more aggressive approach. But this makes absolutely no sense. These medications, disease-modifying therapies, they do not grow new nerve tissue. They do not improve symptoms. They're purely to prevent disability from accumulating. They're purely for preventing relapses, new MRI lesions, and new damage to the central nervous system. So a young person who's healthy, who has low disability, is an excellent candidate for aggressive disease-modifying therapy. Just like if you're treating high blood pressure, you don't care if someone has already had a heart attack or stroke. You still want to control the blood pressure to prevent problems. You don't want to wait till someone has a heart attack or stroke. In fact, some people, if they have very advanced MS, let's say they have neurogenic bladder, they can't drain their bladder, they have swallowing difficulty, they may be more prone to complications of immunosuppressants such as pneumonia from aspiration or severe urinary tract infections. They may not be as good as candidates for these stronger immunosuppressants. So often a young person with relapsing MS with low disability is an excellent candidate for aggressive treatment. I understand that that's counterintuitive, but increasing evidence suggests that these medications are more effective earlier in the disease. Number 2, not treating relapses. So I understand that some doctors may not be very comfortable managing multiple sclerosis in the long run, and they may refer to a doctor like me who has more experience. However, if someone has a significant symptom due to a relapse, say optic neuritis with bad vision, or severe numbness and weakness of the legs due to transverse myelitis, you could at least offer acute treatment. Typical treatments would be methylprednisolone 1 gram intravenously daily for 5 days, or high-dose oral prednisone 1,250 milligrams daily for 5 days. I see patients all the time who had a bad relapse and haven't been offered treatment at all. Number 3, treating a pseudo-exacerbation with steroids. In MS, a pseudo-exacerbation or pseudo-flare is when another physiologic insult to the body causes a temporary worsening of older multiple sclerosis symptoms. Let's say someone has MS and they normally have moderate symptoms, but they come to the hospital with a pneumonia and high fevers, and the weakness in their legs is dramatically worse. Sometimes they'll be treated with both antibiotics and steroids because it will be thought that they're having a multiple sclerosis flare at the same time as the infection, when in reality they just need antibiotics and treatment of the pneumonia. Their weakness will improve over time. Number 4, misinterpretation of JC virus testing. The JC virus antibody is a blood test to see if you have previously been exposed to the John Cunningham virus, and this predicts the risk of getting PML, progressive multifocal leukoencephalopathy, a rare brain infection caused by the JC virus and associated with the MS drug Tysabri. One thing I see is people accidentally check JC virus PCR from the blood, which will always be negative, so you could falsely believe you're negative for the virus. Another thing I see is people test intermediate for the virus and then negative by inhibition, and this is actually a negative test in terms of risk of PML. The last thing I see is people looking at these tests for immunosuppressants other than Tysabri. While it is true that there are very rare cases with any immunosuppressant, for instance, Gilenya or Tecfidera or Ocrevus, the risk is exceedingly low, and a positive JC virus antibody does not necessarily mean you can't take the drug. In fact, the risk of PML with those drugs is so low that it only represents a very small percentage of the infectious complications of those drugs. Number 5, allowing MS drug rebound. Certain multiple sclerosis disease-modifying therapies are immunosequestrants, and there's a risk of rebound severe disease activity upon stopping the drug. These are drugs such as Tysabri or S1P receptor modulators, such as Gilenya, Zeposia, Ponvory, Mazen, that sequester lymphocytes, the B and T cells, in certain areas. They don't kill the lymphocytes, and so if you stop the drug, sometimes those lymphocytes can become active and go right into the brain and spine and cause severe MS relapses, and it's generally not advised to stop them. So for instance, if you planned pregnancy or just wanted to stop the drug for some other reason, it's generally speaking not advised to just stop the drug. There are many known strategies to reduce the risk of rebound, such as, for instance, starting a B-cell depleting drug 1 month after stopping Tysabri. That dramatically reduces the risk of rebound, but you wouldn't just stop these drugs for no reason, except in very specific scenarios, like if someone actually has PML. Number 6, misinterpretation of spinal tap cerebrospinal fluid testing. This is very common. When doing a spinal tap, the cerebrospinal fluid is compared to the blood and placed on an electrophoretic gel, and then it causes the different proteins to move. And if there's more than one antibody, which shows up as a band on the gel, which is present in the cerebrospinal fluid but not present in the blood, this is consistent with multiple sclerosis. About 90% of people with MS have this finding. I've seen many instances of people being told their spinal tap was consistent with MS when it was not. I have an entire video on this topic, link below. Number 7, sending the wrong tubes for CSF testing. When a doctor performs a spinal tap, clear fluid comes out, and it's typically filled in 4 different tubes. Now, when you put in the needle, you're going through vascularized tissue, so you can potentially get bleeding. Ideally, there'd be no bleeding, but it's impossible to avoid it 100% since that tissue is vascularized and you're putting in a sharp needle. Now, the first tube can be contaminated with blood, and typically you would go ahead and send it. But usually the last tube, the 4th tube, you would send for a cell count, looking for red blood cells and white blood cells, just because that's the tube least likely to get contaminated with blood. Now, some cerebrospinal fluid tests aren't that affected by blood contamination. Let's say you're looking for a certain virus like cytomegalovirus in the cerebrospinal fluid. It's probably going to be fairly accurate, even if there's a little bit of contamination. But tests such as the multiple sclerosis panel, you don't want to be contaminated with blood because you're actually comparing the CSF versus the blood. So typically you send a later tube like tube 3, or if you have extra fluid, tube 4. Number 8, doing unnecessary spinal taps. Historically, virtually everyone would get a spinal tap to confirm a diagnosis of multiple sclerosis. But in modern times, we don't necessarily need to do that every time. Certainly the test could be useful to confirm an uncertain diagnosis or even make an alternate diagnosis. However, MRI has gotten so good, and there are very clear diagnostic criteria for MS that many people, if they have classic symptoms and exam findings and MRI findings, they don't really need a spinal tap in my personal opinion, and it's a painful, uncomfortable test, can cause headaches and rarely other complications. Number 9, trusting the radiology report that a new lesion is present on MRI. Radiologists are very good at what they do, and their reports are usually highly accurate, but they're not always perfect in interpreting the clinical significance of what they see. Sometimes the appearance of multiple sclerosis doctor's lesions is highly variable due to the specific technique of that individual scan. Perhaps a lesion was not as well seen on a prior scan and now looks brighter. My experience is sometimes radiologists will interpret a trivial change in the appearance of a lesion as a new or changed or enlarged lesion. It's sometimes spurious. Number 10, misinterpreting white matter changes on MRI as consistent with MS. Many people in the general population have small fluffy lesions in the subcortical white matter. They're known to be associated with migraine and vascular risk factors like aging, hypertension, high cholesterol, diabetes, and smoking, and sometimes they can be misinterpreted as consistent with MS, causing unnecessary anxiety. These benign lesions are known as unidentified bright objects. I have an entire video on this specific topic, link below. Number 11, misattribution of symptoms that are caused by MS to something else, often prior to diagnosis of MS. For instance, I recently saw a patient who had numbness in her feet that spread up to the level of her belly button. Her doctor ordered an MRI of the lumbar spine, and they found a herniated disc, which they believed to be the cause of her symptoms, and she improved, so she thought all was well, but later on she developed other symptoms and was subsequently diagnosed with MS. Now, it turns out that the nerve fibers controlling sensation to the belly button actually come from T10 well above the lumbar spine, so if that doctor knew just a little more about neuroanatomy, they could have avoided that mistake, scanned higher, and made an earlier diagnosis of MS. I've seen many people with MS have their initial symptoms attributed to a different disease like carpal tunnel syndrome or a pinched nerve in the neck and various other neurological diseases. Number 12, the converse, attributing symptoms from another neurological disease to multiple sclerosis. Unfortunately, it's possible to get two things. One of my patients who genuinely has MS had vertigo. I was speaking to her on the phone and was convinced she was having an MS flare. She ended up being seen by one of my colleagues who did a simple physical exam maneuver and diagnosed her with benign positional paroxysmal vertigo, a completely different middle ear disease that was cured with a simple maneuver. What if I had accidentally, erroneously given her high-dose IV steroids, potentially causing unneeded side effects? Number 13, being unfamiliar with the less classic symptoms of MS. Most doctors know the classic symptoms of MS: optic neuritis, pain and vision loss in one eye, numbness from the waist down, transverse myelitis, and certain eye movement disorders like bilateral internuclear ophthalmoplegia, for example. With those symptoms, many doctors will immediately suspect MS. But some are not as familiar with the less typical symptoms or more nonspecific symptoms like fatigue, cognitive symptoms, neuropathic pain, abdominal banding associated with thoracic spine lesions, gait fatigue, the idea that your gait can be okay, but with long distances or in certain conditions you can become weaker in the legs. These are very common symptoms of MS, but some people are erroneously told by doctors that those are not related to MS, even though they are, and many of them have treatments. Number 14, continuing ineffective treatments. Some treatments for MS just don't work for everyone. For instance, Ampera or dalfampridine can help with walking speed in MS, but if it doesn't work, there's no point to continue it. It's not a disease-modifying therapy. It's only worth taking it if it actually has a noticeable benefit. It's reasonable to stop after 3 to 4 weeks if you don't notice anything. Same with neuropathic pain medications like gabapentin. If you try a reasonable dose, it's not effective, just wean off of it and try something else. Sometimes I see people who have a long list of medications, only half of which are effective or needed. And please share in the comments below if you think one of your doctors made one of these mistakes and what was the story behind that, and are there other mistakes doctors make with MS that I left off this list? Once again, I'm not trying to criticize anyone. Medicine is more difficult than it might seem, and anyone can make mistakes. I know I've made plenty in my career, particularly with diseases that I don't have as much experience with. And let me know if you have suggestions for other videos.